Next candidate.
Assalamu alaikum, Dr. Rana.
Hello.
Yes, hello, Dr. Rana.
Hello. Request control.
Yeah, can you hear me?
Yes. Request control, please. 65-year-old male patient presented with abnormal hepatic ultrasound. Go on.
Okay, so it doesn't scroll. Ah, okay. I'm trying to scroll, but
Use arrow. Use arrow.
stuck. Can you scroll for me, please?
Use arrow.
Okay. Okay. So this is a T2 axial sections of the abdomen. There's a problem in scrolling. Sorry. Okay. So of an elderly patient with ultrasound showing hepatic focal lesions.
Correct.
So I'm trying to scroll
Yes.
through the images. Okay. Okay. So what I can see that there are multiple focal lesions within the right hepatic lobe.
Yes.
They are of different intensities, heterogeneous, mostly heterogeneous intensity, hyper and hypo then, and there is a large lesion occupying most of the right hepatic lobe here. This lesion is iso-intense and splaying the vessels with central
Okay. What do you want?
hyperintensity.
Okay. Okay.
Yeah. Okay. So it's iso-intense to the hepatic parenchyma with stellate central hyperintensities within and central focus of hyperintensity. The rest of the organs are unremarkable. So I would like to check these lesions in T1 and T1 post-contrast.
1 second. Look here. This is post contrast. Go on.
Okay, so this is T1 post-contrast, the fat saturated images. I can't trying to scroll again. Okay, so the hepatic dome lesions are heterogeneous with peripheral enhancement, but I would like to compare with the T1 non-contrast to confirm.
Yes, confirm it. What else?
The large central, okay, the large central lesion shows this is the arterial phase, so it shows arterial enhancement with hypo-intense central scar. So I would like to check the delayed images, please.
Delayed. This is arterial. After delayed. After arterial delayed. Take.
Venus, how about the Venus? What the
Yes.
Venus?
Take Venus.
Okay, just
What
wanted to
happened
save
here?
time. Okay. Okay, so there is, I'm just trying to scroll. Okay. So there is no washout in the portovenous phase,
Are you sure?
and
One second, one second. What is washout? What is the definition of
it has the same and enhancement as the hepatic parenchyma, not lower than the hepatic parenchyma. So it's less enhanced, but it doesn't show washout. The
but
central
washout, doctor,
scar appears.
doctor, washout is
Uh,
compared
mm,
with the arterial. Is the contrast decreased here or persist in comparison to arterial?
there there is less contrast enhancement.
So this is washout or not? And
Less contrast enhancement, but
yes, look at other lesions.
as far,
See, one second, one second. I will help you. If we,
okay.
no problem. If this is the arterial, I think this is the venous. Look here, compare, at least is a smaller. See here. Compare those with those. Do you think there are washout or
Mm.
persistent or increasing? This one venous. This is arterial. Arterial, venous.
Yeah,
Where is
arterial
the more contrast?
uh, in the arterial, and the less
Okay.
enhancement in the portovenous.
So it is
Although
washout.
it's not less than the liver. Okay,
Yes. It is
okay.
not less
Some
than
of these
11.
lesions, I think the smaller lesions are less than the liver,
Yes. And even, okay, what else? Look
enhanced
at
less
the
than the
delayed.
liver, the smaller lesions.
See, look at the delayed. What happened? At least,
Um,
what do you
yes,
think? Which pathway these lesions are running in?
okay, there is persistent
The
contrast
delayed.
within the lesion
Okay, in the delayed.
uh, in the delayed phase.
Okay.
So, and there is no um, background hepatic cirrhosis.
Yes.
Um, there is no capsular retraction.
Give me differential.
So my first differential will be um, metastatic liver lesions.
Could you say all of
Second
this,
differential will be multi,
all of this are metastatic?
but this one, because this is the large one. Yeah, but
What else?
the other differential is multicentric hepatocellular carcinoma.
Okay.
Uh,
Yes. What else?
mm, with other satellite lesions.
Okay.
Um,
You are right, by the way. But
uh,
as the liver is non-diseased, it is, see, very homogeneous.
yeah, there is, yeah. Mm.
Very homogeneous. We are worried.
Um,
Hmm.
uh, okay, so they don't show a typical benign
Or
enhancement.
typical malignant. Frankly,
Sorry,
non-typical malignant.
or typical malignant.
What will you do next
Okay.
in this situation?
Um, um, the diffusion will not.
This is
Mm,
the diffusion.
maybe
The diffusion make large is a problem.
diffusion will not add up.
Nearly no obvious
Yeah.
diffusion risk.
Okay.
Increase
Yeah, it will not differentiate the hepatic lesions. Yeah. Um,
very small.
mm.
What
Um,
will you do
I
next?
think um, I think there is no. Mm,
What is your differential here? This is not tested, by
mm,
the way. What's your differential?
yeah. Um, even the large. Mm,
especially for the large one.
Maybe if there's satellite, because of this large one and with central scar, so fibrolamellar carcinoma might be one of the differentials with metastasis.
Maybe. What else?
Um, because of this one, it might be focal nodular hyperplasia,
Yes,
but
yes, you are correct. Very
do we
nice.
have okay? So we can give hepatocellular specific contrast
Excellent.
um,
When will you
to differentiate.
when will you assess in which phase? When you
20 minutes, I think.
20 minutes.
Um,
If this, if
20
in
minutes.
it will take contrast or not.
It will take.
If it
No, it will not. The adenoma will take, but if it's
TC,
fibro,
we differentiate HCC from FNH. If this
mm.
HCC will take or not.
It will take in fibronodular hyperplasia. It will take.
Okay, but in HCC take or not?
HSC will not.
Okay, correct. Adenoma also will not take.
Or
Only.
fibromyalgia will not. Yeah.
Thank you,
And
doctor.
adenoma will not take. Yeah.
Yeah, it is very, very confusing case. Radiopedia mentioned this is
So what was it, doctor? Because
I see.
yeah.
Radiopedia mentioned this is multicentric or multifocal hepatocellular
Mm.
carcinoma. Okay. In my opinion,
Mm.
better to put this case as a case of differentiation or the differential diagnosis. Why? Really,
Differentials.
the contrast is atypical, completely atypical. Why? It should be very important case. The contrast in HCC should be okay. Okay, in the arterial here, hyper enhancement. But in the portovenous, really it should make a good wish out rather than this one. So
Yeah.
we should see
Yes.
this lesion is more and more hypo enhanced than the rest of the parenchyma.
Mm.
Like those,
Mm.
the key here, those smaller, the smaller ones. Why? Because they do good wish out. Okay?
Wash out. Yeah.
Yeah, the key, see here,
Mm-hmm.
hyper enhancement, and here, see, good wash out. And they contain necrotic hypointense center. Look in the T2, it will be cystic. Cystic. See? Central cystic.
Mm.
Changes. The key here, not the large lesion, by the way, is the smaller lesion. And another point of difficulty is the regular uh, border of the liver and the homogeneous parenchyma. In my opinion, better to talk about two differential diagnosis. But as the patient is elder and we have others, other smaller, more malignant or more in the direction of malignancy, so it is most likely HCC rather than FNH. Thank you so much. Next candidate,
Thank
request.
you, doctor.
Welcome. Request.
Assalamualaikum, sir.
Assalam. Doctor, this
I
is,
requested.
yes, 55-year-old patient presented with abdominal pain.
So I have been provided with a T2 non-fat set image. I can see that the
Are you sure, doctor?
it's likely it's T1. It's T1. It's T1
Yes, sure.
in non-contrast image. I can see that the liver
Scroll,
shows
doctor. Doctor,
reg
scroll. Please scroll.
I am scrolling. I am trying to scroll. It's not happening. I'm sorry.
No problem.
Sir, can you scroll for me, please? So the liver shows normal, regular margins. I can see that the gallbladder is collapsed. There is mild fat stranding in the kidneys bilaterally. I cannot see any lesion in the liver on T1 sequence. Okay, so on this is T2 sequence. I can see that there are multifocal small T2 hyperintense cystic lesions in the liver, which are present in both right and left lobes. These appear very regular in shape and appear cystic and T2 hyperintense. There is no significant soft tissue component in this lesion. I would request post-contrast sequence to look for any enhancement in these lesions.
Doctor, what happened here?
So this is outface image. In the outface image, the previously lesions are not visualized. On T1 in phase, they were also. This appears to be a focal diffuse fatty infiltration, which is becoming hypointense in the outface image. This was hyperintense in the in-phase image. This is
So,
a diffuse fatty infiltration focally.
so
My findings include diffuse fatty infiltration along with multifocal T2 hyperintense, which could represent biliary hematomas.
this is
There is
not
no,
diffuse, doctor. This is patchy. Look, geographical.
yes, this is patch, yes, this is patchy, yes, this is patchy focal fatty infiltration, which is becoming hyperintense on the outface images. And the previously seen T2 hyperintense lesions on the T2, they could be biliary hematomas because they were very regular shaped and no soft tissue component. I would confirm my findings on post-contrast
One
images to
second.
look for any
One
enhancement.
second, doctor. Very regular or irregular?
Uh, they appear very smooth shaped. They are not irregular. They are very rounded and few appear
Yes, you
oval
are correct.
shaped and they appear
So,
cystic.
so
Yes,
this is
yes.
against or with biliary hamartoma.
I guess this is typical of biliary hematomas. There are no
No,
soft
no,
tissue
no,
components in
no, no,
these.
no, no, no. Biliary hamartoma is very characteristic with one buzzword, bizarre shape. Bizarre shape. Okay?
Okay.
So, so,
Okay.
give me another differential.
So um, this could represent multiple liver cysts. I would look at the
Excellent.
kidneys for any cystic areas in the kidneys. If there are multiple cysts in the kidneys, this may represent polycystic disease process.
Okay, doctor, if you have reversed T out and in and out phase images. This is in, this is out. Okay, this is in, bright, out, drop. If you have the reverse, the opposite,
Yes.
what will be your diagnosis?
That will be hemochromatosis. That will be iron overload. It is low on in phase and high on the out phase images. The appearance appears reversed on the hemochromatosis
Thank you, doctor, so
and the
much.
deposition diseases.
It was a case of patchy infiltration, fatty infiltration of the liver. Thank you. Next candidate. Next
Yes,
candidate.
sir.
Request control.
Yes, sir. I can't. I'm on mobile.
Okay. Doctor, this is 55-year-old female patient with abdominal pain. Go on.
Okay.
Let's start.
So I'm presented with MRI. Yes, abdomen of a 65 years old female with abdominal pain. I would like to check the study before starting my comments. Would you kindly scroll for me?
Okay, doctor. One by one, doctor. Let's start one by one.
Okay.
Tell me what is the name of this sequence?
Okay, this is T1.
Okay. And this one?
Okay. Fat sensitive. This one is, I think, out of phase.
Yes. And what is this?
I think it also looks like out of phase.
Okay, this one. What is this?
Okay, so this will be in phase.
Okay. Look again. This is in phase. This is out of phase. What is this? Look at the CSF or at this one. So what is
Yes, this is T2.
excellent? Let's concentrate here. What happened?
Okay, so on this T2, I can see that the liver shows marked decreased signal intensity, diffusely involving the entire liver. The liver shows smooth outlines with no abnormal focal lesion that
What
could
else?
be identified, no biliary ductal dilatation.
What else?
Okay, I would like to check for the rest of the organs. The spleen is also a flow signal. The bone marrow is within normal. I would like to check for the pancreas, the adrenals, and for the rest of the scan. Till this point,
Did you find
when
any
comparing this with the,
Did you find any?
pardon me? Yes, there is an abnormal soft tissue intensity seen to the left of the left diaphragmatic cross. I think it could be related to the suprarenal region on the left side.
Okay.
Yes, involving the medial limb of the left adrenal gland. It is of low signal intensity on this T2. So I would like to check it on the T1 and the post contrast.
No post contrast. This is
So,
in phase. This is out of phase. In phase, out of phase.
okay, so there is signal drop
Hmm.
on the out of phase sequence denoting fat content, intracellular fat. So this is adrenal adenoma on the left side.
Okay, doctor. Doctor, if we have only CT and you have adrenal mass, what would you do?
Okay, with contrast, I would like to do the washout study ratio. That is the HU on the plane, the HU on the arterial, and the delayed. Applying the equation and get the washout ratio. If more than
After how
60%,
long?
it's benign. If
1 second. After how long you will take the delayed?
I think 15 minutes.
Excellent. What is the difference between adenoma and metastasis or any other malignancy? How can you
Okay,
differentiate?
adenoma is usually okay. If from the start it shows fat density
Okay, what else?
plus or minus 10 HU, then this is definitely adenoma. If it is enhancing, no fat, showing increased washout, then this is suspicious for other pathologies, including metastasis and neoplasms.
Okay, what else? What about the washout, the contrast? What is the measurement?
60% is the cutoff point. If more than 60%, then I would suggest it's a neoplastic.
Okay, excellent. There are relative and absolute washout. There are two types. At least tell the examiner one is
Yes.
50% and the other is 60%. Okay, what about the size? Which size in favor of benign adenoma or adenoma?
I think 1 centimeter in favor of benign lesions.
How
If
much?
more, then would be suspicious.
How
1
much?
centimeter.
1?
1 centimeter.
No,
Yes.
no, increase. Increase, please.
Okay, so 5.
From 1 to 5? Okay, okay. I think between 5 or 4. I didn't accurately remember the number, but any mass above 4 and 5, you should suspect malignancy. Any mass is less than 10 HU, 10 HU house field unit, it is in favor of benign. Okay, sure. If it is contain any fat
Yes.
component, it is benign. Thank you so much, doctor. It was
Lipid rich, yes.
Yes, it was a left suprarenal or adrenal adenoma. Thank you so much. Next
Okay,
candidate.
thank you.
Okay.
Next is 12, please. I mean 13.
Okay.
Assalamu alaikum.
Alaikum salam. Request control, doctor, please. Doctor, request control.
Yes, sir.
Go on.
These are T2 weighted MR images of the lower abdomen and pelvis. First, I will scroll the whole of the image, then I will tell the pathology. Heterogeneous echogenicity, peripherally hypointense and centrally hyperintense. Collection or mass-like thickening seen in the mid-abdomen.
Yes.
Yes, sir. Yes. Which is adjacent to the bowel loops, not not separately visualized. There
Yes.
is associated fat standing. It is abutting the uterine surface. I am trying to concentrate on the appendix, which is not separately visualized.
So what's your differential?
So it can be perforated appendicular abscess, phlegmon formation, or right tubo ovarian abscess. I
Excellent.
would like to see the sagittal T2 weighted images for sagittal T2 weighted images to
What
see the
happened
uterus
here?
and ovaries.
What happened here?
There is restricted diffusion of this collection.
Yes.
These are DW weighted images. There is restricted diffusion of this collection.
And extended to the cecum.
And a tubular, yes, yes,
I think this is appendix. See this one. See,
yes, the tubular structure is also seen.
it has defect here, I think. Okay. Finally, what's your diagnosis?
Perforated appendix with phlegmon formation.
With abscess. Abscess formation, not phlegmon. Is this phlegmon
Yes.
or abscess?
Sir, it shows a restricted diffusion, then this is an abscess.
What is the difference between abscess
But
and
there is surrounding fat standing is also present.
okay. What is the difference
Sir,
between
phlegmon, yes, sir.
yes?
Sir, abscess is cystic and shows restricted diffusion, while phlegmon is a solid intensity mass, which does not show restricted diffusion.
No, not. Yani this is not the main point. There are one buzzword
Okay.
to differentiate between abscess and T2 and phlegmon. What is this?
Sir, bright signals, central
Yeah.
bright signals,
Bright signal of what? Solid or fluid?
fluid.
This is the difference. No other words. The phlegmon is granulation tissue, completely granulation tissue.
Yes, sir.
After proteolytic enzymes released from the white blood cells, there are destruction here. This is destruction, okay, filled with
Okay, sir.
proteinaceous material. So this is the cavity of the
Yes.
abscess, okay? So
Okay.
phlegmon is complete granulation tissue. Abscess is containing central breakdown, central cyst, central collection. Thank you so much, doctor. This is very
Thank you, sir.
important also in spine and the NTP. Our management here may be drainage. First, this patient, I think, need drainage. And after that, they will do surgery. Doctor, do you think the surgeon can do surgery in this situation? Yes or no?
No,
Surgery,
sir.
I mean appendectomy. Yes or no?
No, sir, because there is chances of infection and peritonitis in this patient if, and the wound will not heal properly.
Okay.
There are more chances of post-operative complications.
What else? This is the task of the
There
radiologist.
can be formation of
Yes.
sinus tracts and fistulas after
Excellent.
that.
Excellent. So this is the task of radiologist to detect any appendicitis complication. Why? Any other than catarrhal appendicitis, it may lead to fistulas. By the way, I work for few years in surgery. Okay, part-time. I saw what is post-appendectomy fistula. It is very, very irritant. It take 1 month to heal. We have one patient, he stay in the hospital 1 month, and the surgeon can't do anything for him. Just follow up, just wait. Okay? Okay, my colleague, it was a mistake from one radiologist because this patient was was not didn't have pure appendicitis. He has appendicular mass, means the appendix was so inflamed and surrounded by omentum, and the tissue was were friable. After appendectomy 2 days, the incision, really I saw by my eyes, the incision site was oozing stool, unfortunately. So it is our task to diagnose any complication from appendicular pseudomass up till abscess, pancreatitis, appendicitis, peritonitis, any other complication. It is very important. Thank you so much, doctor. Next candidate.
Thank you, sir.
Okay.
Sir.
Salam. Request control, doctor.
Yes, sir, I requested.
Okay. Doctor, look here. Yeah, what happened?
So I've been presented with the axial MRI images, FAT-SAT.
Yes.
So I'm not able to scroll, but I'm trying. First, I would like to scroll to the whole images.
Yes.
Do I have a history or anything? No, sir.
He have some discharging opening.
Sir, sir, I'm not able to scroll good.
Leave the mouse. Leave.
Sir, I can see subtle ascites, free fluid in the pelvis. Apart from that, the bladder appears to be normally outlined.
Look posteriorly. Doctor, look posteriorly. More
Look
posteriorly.
for, sorry, I can't hear you.
Look
All posterior.
more posteriorly.
Sir, in this image, sir, there is a subtle shadowing, low signal noted in the base of the bladder.
No, no, no.
It could be
Look,
thick and wide.
look at the natal cleft. What
Sir, I
happened?
can't hear you, sorry.
Look at the natal cleft. What happened?
Natal cleft. Sir, natal cleft. Sir, there is a high signal that is noted at the natal cleft. Linear high signal, if this one.
Where?
And it is seen. Okay. Sir, this one. This one.
This is the natal
So
cleft.
this is if.
See, 1 second, 1 second.
Yes,
This
sir.
this
Yes,
is
sir.
the natal cleft itself. Okay?
Yes, sir.
See, tell me,
So can you scroll again? Yes, sir. I will see.
what is this? Follow this abnormal signal? Follow?
Yes, sir. Yes, sir. This is a high signal noted at the natal cleft that is extending with an external opening at the level of the natal cleft and extending upward to involve the sphincter. I would like to see the sphincter itself to see its extension is transsphincteric or it is extending above the sphincter. So if you can scroll for me, sir, because I'm not able to scroll.
Look, sister, doctor, sorry. Do you think this is a pre-sphincteric lesion or something else? By the way, this is the tip of coccyx. The lesion is more posterior.
This is the tip of coccyx and this is the high signal.
Yes.
So it
Look,
can be a sinus
yes, where is it?
rather than a fistula.
Yes, where?
Sir, it is at the level of the coccyx
Okay, what is the name
on
of
the dorsal surface, on the dorsal part, sir.
what is the name of
So
sinus?
it's dermal something. Sir, I don't remember exactly. Sorry. So I would like to sir, dermal sinus. So
Okay,
it is a pilonidal sinus, sir. Pilonidal
brilliant,
sinus, sir.
brilliant.
Yes, sir.
Thank you, doctor. It
Yes,
is
sir.
very, very difficult because most of us do it only in ultrasound. But anyway, let's to be familiar with for us. See, my colleagues, it is in the nasal cleft to the right. What happened? Abnormal track of bright signal containing fluid. This is typical but very small pilonidal sinus. May contain hair. Sure, it contains fluid. Sometimes it is the patient presented with infected pilonidal sinus. Thank you, doctor, so much. Next candidate. Hello.
Sir, I'm candidate 17.
Okay, Dr. Nagam, last candidate. This is the last.
15 is around, please. If 15 is not here, then 17.
Okay. Doctor, request control, please. 85-year-old,
Sorry, I'm on mobile phone.
85-year-old male patient presented with
Okay, sir.
painless jaundice. What happened?
Okay, sir. Sir, I'm provided with star images. I could appreciate that there is intrahepatic biliary dilatation, more so in the left lobe, the extrahepatic biliary ducts also seem dilated. Yeah, the extrahepatic is also dilated. Sir, can you please scroll down a little bit slowly? Sir, the gallbladder is well distended. Sir, the pancreatic duct is not dilated. I could appreciate a filling defect within the. Sir, I'm unable to follow. Yeah, could you scroll slightly?
Okay.
Sir, the coronal images again shows the dilatation of intra and extrahepatic biliary tree. Yes, and sir, I could appreciate that the cystic duct has a low insertion.
Okay.
So I'm looking
Do you
at this
remember?
one.
Do you remember
Transition point for
the
the.
patient age?
Sorry, sir.
Do you remember the patient age?
But I think so. Yeah, he was a young boy.
Yani, he is young, but not so young. He's just 85. Not young at all.
Oh, 85 years old. So
Okay. Not young at all.
very old.
He is
So, yeah,
elder than,
elderly male. Sorry.
see, he is elder than Trump.
Yes. Sir.
So,
So I'm thinking some abrupt narrowing at the distal CBD,
okay.
distal at the site of beyond this point.
Is this pancreas acceptable for you, for the age of patient?
No,
Hmm?
sir. The pancreas also appeared bulky.
Appear what?
There is no bright signal. Sir, bulky.
Excellent. What else? What
Uh,
else? What happened to
sir,
pancreas?
in addition,
So there is stranding noted at close to the tail of pancreas and distal body.
What happened?
It's Sir, I could appreciate slight stranding near the tail of pancreas.
Okay. What else? So, sorry, 1 second. I think
Yeah, I think the place has changed.
we lost the case. One second. What happened for the pancreas? Look here. Look here.
Sir, it's significantly bulky
Yeah.
with loss of.
Hello?
Sir, I think there is some mass, bright lesion noted in the head of pancreas.
Mass? What else? What about the
Then,
outline? Look at the outline of the pancreas.
yeah, sir, it appears smooth. There is loss of interdigitation, then
So,
it appears smooth.
okay. What are you worried about? Markedly dilated
Sir,
biliary system and swollen
diffuse enlargement of
pancreas.
pancreas. Sir, I am thinking of. Sir, can you show me DWI?
It will not, it will add nothing.
Sir, then. So it's not the typical age for autoimmune pancreatitis. I'm thinking of some malignancy. So
No,
it's bright on DWI. Could it be lymphomatous deposition in the
no, no,
pancreas?
no. See. We have some pancreatitis and we have, see, what happened for the biliary tract here? What happened? What is this?
Says this is a periductal hyphen, maybe
Yes,
cholangitis.
cholangitis. What mean pancreatitis, pictureless pancreatitis, or and what is this? Inflammation of the biliary tract, cholangitis. Collect both of them in one word, please. Which disease is the cause, is the underlying etiology of both of them? Which disease?
Cholangitis and pancreatitis.
Yes,
So,
something sure, autoimmune.
HIV,
Autoimmune, sure. What is which?
autoimmune pancreatitis. Sir.
Yes.
Okay.
Which autoimmune disease? Hello?
Sir, I can't remember. Sir, I can't remember.
Do you hear before about IgG4?
Yes, sir.
This is IgG4 disease. Consisted of autoimmune pancreatitis
Okay.
and cholangitis, sclerosing cholangitis. What happened? See, my colleague, what I just said this advice today. This is, I think, third time. When you saw very old patient and you have cross section of the abdomen, in my opinion, first of all, look at the pancreas. Why? Because this size is not acceptable for this age. Very large. Number two, absence of of vegetation. So this is sausage shape pancreatitis or pancreas. Number three, from the beginning you detect this biliary dilatation. Okay, but in my opinion, the key here is in the pancreas itself. Okay, it is very easy to detect. By the way, doctor, I think this one is maybe CBD. I think no, not CBD. Anyway, this is autoimmune pancreatitis. sausage shape associated with marked dilatation. And see here, it is dilatation, narrowing. Looks like beaded shape. This is beaded shape biliary system. So this is sclerosing cholangitis. Finally, the answer was IgG4. IgG4 disease. Thank you for all of you, our colleagues. I think tomorrow will be our last session. After that, I will take about 2 to 3 weeks vacation. I will try to give you any sessions, but I didn't sure. I'm not sure at all. So try to attend tomorrow, and after the vacation, I will continue to give our sessions until October exam. Thank you so much, Dr. Nagam. Thank you for all of you for attendance.
Thank you. Thank you so much, Doctor.